Greetings from the Insurance Institute of Indiana. I'm Marty Wood, the president of the Insurance Institute. I guess it's another year where we will have to do this electronically and won't be able to do it in person together, so we'll look forward to next year when we can all be in the same place to discuss the activities of the policymakers making policy for the insurance industry in Indiana. I don't have to tell all of you what all we've experienced over the last year plus in regard to how COVID has affected everyone, but as we went into the 2021 legislative session, there were a lot of questions about how the Indiana General Assembly would operate dealing with COVID. And it was definitely a learning experience for both legislators and those of us who interact with the legislature on a regular basis, as the normal amount of time that we spent together was curtailed significantly. Legislators were isolated in committee hearings. We would actually testify from a different room on video and answer questions that way. And it was a trying process, but the legislature did adjourn at the end of April. The main issue going into the session for the insurance industry, as well as the general business community, was dealing with COVID liability. And fortunately, that was the main priority for the General Assembly, as well as both Senate Bill 1 and House Bill 1002 were introduced as companion bills dealing with COVID liability. Senate Enrolled Act, as it actually was called when it passed, Senate Enrolled Act 1 was the primary bill dealing with focusing on immunity for both premises and product liability related to COVID-19. This bill ultimately was signed into law on February 18th, the earliest I remember a bill being signed into law in my time dealing with the legislature. But it broadly defined COVID-19 protective products, and it provides civil tort immunity. Included in this would be personal protective equipment that companies had repurposed to provide for the safety of Indiana citizens, as well as medical devices, medications, and equipment used to treat COVID-19. Again, this was a joint effort between all types of business as well as the insurance industry. We'd spent a lot of time working on it in the fall, into the winter, going into session, and legislators were very receptive to the suggestions that had been made. Again, that bill passed on February and was signed into law on February 18th. The companion bill, House Bill 1002, was a more expansive immunity bill, which included immunity for healthcare providers as well as governmental entities and the employees of government. Both of these bills also contain prohibitions on class action suits against those who provided the services during the pandemic over the last 14 months. So it was a positive development early on in session. With both of those bills moving through very quickly, we were able to focus on some other key issues for the insurance industry that we had not necessarily thought we would be able to get to in this coming session. And the majority of those issues were contained in House Bill 1402, which ultimately did pass the session. House Bill 1402, it was 1405. House Bill 1405, one of the primary things that was contained in that deals with rebating. This is an issue that we had talked about, companies, agents, for a number of years. The National Association of Insurance Commissioners, as well as the National Conference of Insurance Legislators, had put together model legislation over the last few years, and ultimately working with State Representative Matt Lehman, insurance agent here in Indiana, and the president of NCOIL, we were able to put forth a proposal that would provide for modernization of the rebating statutes we have here in Indiana. With the passage of the bill, we now have language that allows for insurance companies or agents to utilize rebating as it's defined in a way that says that as long as you are primarily using whatever the product or whatever you're providing to the consumer, you're using it primarily for risk mitigation, and there is a nexus to the insurance industry, then you can use it. There was some effort to try to restrict that even more, but ultimately the word primarily seemed to be the one that made the most sense and allows for a little bit of flexibility in providing seminars and things of that nature as a risk mitigation rebating product. Also established within the bill is that a new threshold will be in place for the amount of either cash or prizes that can be awarded or given out under the rebating statute. The cash amount will now go up to $250 before the rebating law triggers in, and the prizes amount will be up to $500. Again, we think this is a good modernization of the rebating statute. Also contained in House Bill 1405 was a provision that says that if an individual consumer purchases a product through electronic means, the correspondence future providing that policy, any renewals, will be provided automatically through those electronic means. The individual can opt into receiving those through paper and in the mail, but if they have purchased it electronically, the default will be that they will receive it electronically. And then finally, also within the bill was affixed to a court case that caused some confusion as far as the delivery of policies and other documents to the consumer. The language in the law said that delivered was an ambiguous term, and so we actually fixed that to make it clear that once the policy or the documents were mailed, that met the timeline of delivery to the consumer. A final bill on the property and casualty side that was of interest to the insurance industry was House Bill 1125. 1125 is attempting to address deceptive advertising. Many of you, I'm sure, have seen at various times the commercials on TV where it's clearly from a law firm saying, if you've been impacted by this, contact this law firm and we might be able to get you money. Well, a lot of times these ads are fairly deceptive. And so House Enrolled Act 1125, as passed, addresses medical devices and legend drugs. It will allow for any deceptive advertising that takes place to have action brought against those who produce the advertisement. We hope that once this has been established and in place, we'll be able to take this to a longer, wider breadth where it'll go beyond the medical devices and the legend drugs and start to address other types of advertising that these trial lawyer organizations put out. Now, a development that took place since the last time the PIA had their convention for the Insurance Institute is that we have actually taken over the management of the Indiana Association of Health Plans. So we got our hands now into the health arena. And this legislative session, no surprise, but health issues were at the forefront of a lot of discussion and a lot of the controversy that took place. Primarily was dealing with pharmacy benefit managers. For those of you who know, pharmacy benefit managers are different types of, a lot of times, insurance-run operations that provide pharmaceuticals at a much more reasonable rate than you can find at your corner drugstore or certainly in the hospital pharmacies. And there's been a lot of question amongst policymakers about whether or not these are properly regulated. In both 2019 and 2020, legislation was put forward to provide more regulation on these pharmacy benefit managers. This year, the legislature decided to go in and go after it even more. So one of the key things that came out of it was an update to what's called the Maximum Allowable Cost List, or MAC list. What it provides is that those lists, which is the maximum amount that a pharmacy benefit manager will pay for a given drug, must be updated every 7 days. Previously had been every 45 days. With the amount of volatility in the pricing of drugs that are out there, drugs are often going up and down as far as those prices, and pharmacy benefit managers must adjust their MAC list to accommodate for the volatility of those prices. So now the PBMs are being required to update those lists on a 7-day basis, at least every 7 days. It also requires PBMs to make sure that the drugs that are provided on the MAC list are generally available, that they are not obsolete, that there's not a low supply. So PBMs will have a further burden where they will have to make sure that those drugs on their list are available when pharmacies go in and check on those prices. It allows pharmacists to appeal to the Department of Insurance when they have been denied an appeal to the PBM. They can appeal those prices to the PBMs, and the PBMs must respond, and oftentimes those will be denied, and if denied, they can then go to the Department of Insurance. Once the department has received the appeal from the pharmacist, the PBM will be given 20 days where they will have to respond back in writing to the department on how they are going to address the discrepancy between what the pharmacist has indicated and what they have on their MAC list. So a variety of things dealing with PBMs that will continue to evolve, no doubt, over the course of the next few years. Another issue that came up during the session, this came about 2/3 into the session, deals with an issue that is commonly referred to as white bagging. This is dealing with specialty drugs, typically for cancer patients, that are produced understandably at a high rate. Unfortunately, what the insurance companies were finding out is that hospitals admittedly were marking the prices up on these drugs some 4 to 5 times, 400, 500%, to produce them in their own pharmacies on site. The insurance companies have, over the last couple of years, countered back by creating their networks that would allow the hospitals to pharmacies to join their network and provide it at the cost that the insurance company knows they could get it for outside of the hospital. If they chose not to do that, that's where the white bagging kicks in, and the white bagging means that the insurance company will send the drug to the hospital at their cost and provide it for the services to that patient. The hospitals have argued this endangers the life of patients because they can't be assured that they are going to receive the drugs on time. The insurance companies have assured everyone that there are protocols in place to make sure that those that are there on time. But again, we also offer up that if you just simply, the hospitals join the network, they will be able to have it produced on site and provided to that patient. The reason this came about late in session is on April 1, Anthem Insurance, who insures more than 60% of the insured lives in Indiana, started to utilize this process with their network. And Since that time, it's been found that 90% of the hospitals have opted to join the Anthem network who utilize Anthem insurance. That tells us that it's recognized that they needed to go this direction. However, there's still question within the legislature as to whether or not more safeguards need to be put in place. And so legislation was passed that will require there to be a study on this issue done by the Indiana Department of Health in conjunction with the Department of Insurance, the Pharmacist Board, and FSSA to study the issue of white bagging, and they will be reporting back to the Indiana General Assembly by July 1 of this year. So it'll be a fast-moving process, and one that we don't think will be put off until next session. It could be something we're addressing later on this year, and I'll explain to you why in a minute. Another issue that was brought up during the session was the all payer claims database. This is an issue that had been passed by the General Assembly in 2020, creating the database. However, there was no real teeth to it. This year, the General Assembly created an advisory board for the all payer claims database and requires the Department of Insurance, again, to establish rules governing the collection of the data as well as the distribution of data. Funding was put in the budget this year at $4.1 million for this coming year, and the second year of the biennium, $1 more million to fund the all payer claims database. Probably the biggest issue in health that legislators like to talk about is price transparency. This is an issue you hear talked about across the country. A couple of issues that were brought up on price transparency here during the legislative session, including requiring hospitals and health carriers to hold annual public forums. This will be able to be done either electronically or in person, but from the health carrier standpoint, health insurers will be required at these public forums to provide updates on premiums, justify premiums, as well as post on their website strategies that they have to lower healthcare costs, and if it is a publicly traded company, they'll need to list Indiana-based profits as well as provide a copy of their annual audited financial reports. Obviously, hospitals also have requirements on them as far as their public forums go, but this will be interesting to see how this one plays out over the course of the next few years, how much of the public actually pays attention to these, and whether it is worth the cost to all stakeholders to actually do this. Finally, we get into some future studies that are coming out for this coming year or two dealing with health insurance. I already mentioned the white bagging study. In addition, there's going to be a market concentration study that's going to take place over the next 2 years. That will include medical providers, medical payers, insurers, business. All aspects of the health insurance or health care industry will be studied over the next 2 years, with a report due back to the legislature in December of 2022. We're hoping this means that the 2022 legislative session will not be focused so much on health issues as they let this study play out, but we won't hold our breath on that one. But that is one other study that's being put in place. And finally, the Department of Insurance had another burden placed on them, as they will be required to conduct a study over the next few months dealing with employers putting together multiple employer welfare arrangements and how those can be updated to allow employers to provide the health coverage to their employees. So I've mentioned a number of ways the Department of Insurance has had a lot of responsibility thrust on them: regulating the pharmacy benefit managers, the white bagging issue, studying MEWAs. That's in addition to last year having put the data breach security for the insurance industry under the Department of Insurance rather than the Attorney General, a move that we supported and strongly felt was the right move to make. The department's also been conducting studies on public adjusters. There's a lot that is being thrust onto the Department of Insurance by the Indiana General Assembly, and we have significant questions about whether the appropriate funding has been put in place and whether it exists to allow the Department of Insurance to do this. And if the funding's not there, that probably means some of the expertise is not there. Because on pharmacy benefit managers, this is an issue that no one within the department has ever regulated. In fact, states have not regulated that until this coming year. So this is a real challenge that the Department of Insurance faces. Having said that, probably the biggest news regarding the insurance industry to come out here during the legislative session was the announcement that Indiana Department of Insurance Commissioner Steve Robertson would be stepping down from his position as commissioner on June 1st. We are now 1 month away from that happening, and frankly, I cannot give you any answers on what direction the governor's office is going to go. We've heard rumors of various names of people who are interested in becoming the insurance commissioner. However, no indication has been given by the governor's office on what direction they will be going. The Insurance Institute has a request in to meet with the governor's office to discuss not necessarily an individual person for that position, but some of the criteria that we think should be met for that person coming in and what they bring to the table in helping to regulate the insurance industry in Indiana. Obviously, they've got their responsibility of just general oversight for the industry, but they also must manage and maintain a staff that I think most of us believes are a pretty good insurance department, but there are going to be movements, there already have been movements away from the department by certain staff members, and those roles are going to have to be filled, in addition to the new roles that are being created by the General Assembly. So managing and maintaining staff is going to be critical on the part of the new insurance commissioner. Then you've got the responsibilities this person plays on a global level at the National Association of Insurance Commissioners. There are 50 plus members of the NAIC, and not all of them bring the same Midwestern values, Indiana perspective that we really need the insurance commissioner from Indiana to bring. And it's not right, in our estimation, for it simply to be the East Coast and the West Coast dictating what policies come out of the NAIC that then we need to live under, especially when it comes to accreditation. And no doubt there will be accreditation issues coming up over the next few years. Again, an issue that the new commissioner is going to have to get up to speed on. Hopefully they have some kind of idea of what accreditation means. We need him to be an ambassador for the insurance industry. Somebody that can go around and meet with those people who represent the insurance industry in Indiana. We have not had a real outreach from the Department of Insurance for quite some time to our agent members of the industry, to our company members of the industry. And we need somebody that comes in who has a perspective and also preferably a relationship with all of us going in. And finally, somebody that has an idea maybe how to grow the industry in Indiana. While we feel like we have a very vibrant insurance industry, property and casualty, life, health in the state, we've seen so many companies, mostly through mergers and acquisitions, but so many companies leave the state. We have agencies who are being bought up. We'd like to grow the industry rather than see it constricted. And so we'd like to have somebody come in who has a vision on how we might be able to do this. As Matt Lehman told me just recently when he and I had a conversation, he reached out to the governor's office and said, this position is too important to make it a political appointment. This is a position that needs to be filled by somebody with an insurance background who is ready show the vision of where we could go as an industry across the state. So we will keep you posted on all of those developments. In the meantime, always feel free to reach out to the Insurance Institute or reach out through Scott to the Insurance Institute if you have any questions that we could answer. In the meantime, we will continue to fight the good fight and look forward to being back in person again next year. Thank you.